Welcome to the deep dive. Today we're getting into pharmacokinetics. Basically what your body does to a drug once you take it. Think of it like the drug's whole journey inside you.
It's a critical journey.
Yeah, and we're looking at a presentation that covers, the core stuff.
Yeah.
ADME, absorption, distribution, metabolism, excretion, and also a bit on therapeutic drug monitoring.
Right. The goal is really to unpack these concepts, make them clear, show why they matter for how medicines actually work for you.
Exactly. So understanding this journey helps figure out, how a drug will affect you, the right dose, maybe potential side effects too.
Absolutely. Let's kick off with absorption. How does the drug actually get into your bloodstream?
Okay, absorption, the entry point. Our source material shows a few main ways this happens.
Yeah.
Some drugs just use passive diffusion. They kind of slip across membranes, especially if they're fat soluble. No energy needed.
Simple enough.
But others need active transport. They actually use energy to get moved, sometimes against the flow. Levodopa is an example, apparently.
Right. Needs a specific mechanism.
Then there's facilitated diffusion, needs a carrier molecule like glucose, and filtration for really small molecules through pores.
Okay.
And even endocytosis for bigger things like vitamin B12, where the cell just engulfs it. So lots of ways in.
And, how you take the drug makes a huge difference here. A pill, for example, has to dissolve first in your gut.
Right. Which leads to bioavailability, how much actually reaches the blood.
Exactly. And related to that is first pass metabolism. Super important.
That's the liver thing, isn't it?
Yeah. When you swallow a drug, it goes through your gut wall and then straight to the liver before it gets circulated everywhere else.
And the liver can get down a lot of it right away.
It sure can. Reduces the bioavailability quite a bit for some drugs.
But the notes mention ways around that, like nitroglycerin under the tongue.
Yep, sublingual.
Yeah.
Or lignocaine given intravenously, IV.
So you bypass that first hit from the liver, more drug gets where it needs to go, and faster. Okay, so it's absorbed, it's in the blood. What happens next? Distribution.
Correct. D for distribution. Now the drug travels from the bloodstream out into the different tissues and organs.
And there's this concept, volume of distribution, VED.
It's a way to think about how widely the drug spreads out. Is it staying mostly in the blood or is it going deep into tissues?
So warfarin has a low VED, stays in the blood mostly.
Pretty much. Well, something like chloroquine has a really high VED. It gets concentrated in tissues.
Interesting. And then there's the blood-brain barrier, the BBB. That's like a fortress for the brain.
A very selective one, yes.
Yeah.
Protects the brain. Usually, only drugs that are lipid-soluble, fat-loving can cross easily. Diazepam is a classic example.
But inflammation can change that sometimes. Make it leakier.
It can, yeah. That's an important exception.
Okay. Absorbed, distributed. Now metabolism. The body starts changing the drug structure.
Right. Biotransformation. The body is essentially trying to make the drug easier to eliminate, usually by making it more water-soluble.
And this happens in phases, phase 1 and phase 2.
Typically, yes. Phase I reactions, like oxidation, reduction, hydrolysis, they often involve those CYP450 enzymes you hear about. They add or expose a functional group.
Okay.
Then phase 2 is conjugation. The body sticks another molecule onto the drug like glutaronic acid or sulfate, making it bigger and usually much more water soluble, ready for excretion.
And other drugs can mess with these enzymes, right? Induction and inhibition.
Exactly.
Yeah.
That's a huge deal in medicine. Some drugs, like rifampicin, are inducers. They speed up the enzyme.
Meaning other drugs get broken down faster, maybe don't work as well.
Precisely. Less effective. Then you have inhibitors, like erythromycin. They slow the enzymes down.
So other drugs hang around longer, potentially reaching toxic levels.
That's the risk. That's why knowing all the medications someone is taking is absolutely crucial.
Makes total sense. Okay, so it's metabolized. Now it needs to get out. E for excretion.
The final step. Mainly handled by the kidneys.
How do they do it?
3 main processes there. Glomerular filtration unbound drug just gets filtered out of the blood. Then tubular secretion active transport pumps drugs into the kidney tubules.
Active again?
Yep. And finally, tubular reabsorption. Some drugs can actually slip back from the tubule into the bloodstream.
Oh, really?
Yeah, and urine pH can influence that last step. Like the example given, if someone overdoses on aspirin, you can make their urine more alkaline, maybe with sodium bicarbonate.
And that traps the aspirin in the urine so it gets excreted faster.
Exactly. Reduces reabsorption.
Clever. Okay, the notes also touch on therapeutic drug monitoring, TDM.
Yeah, PDM. It's really important for certain drugs, especially those with a narrow therapeutic index.
Meaning the gap between a helpful dose and a harmful dose is small.
Very small. Think lithium, digoxin, phenytoin. You need to monitor blood levels carefully.
And phenytoin has that weird kinetics thing. 0 order at high doses.
That's right. Most drugs follow first-order kinetics. You eliminate a constant percentage per unit time. But with 0 order, like high-dose phenytoin, you eliminate a constant amount. The system gets saturated.
So it doesn't clear faster if you have more?
Nope. Which makes overdoses tricky. And generally, for most drugs, you reach a steady concentration in the body after about 4 to 5 half-lives.
Good rule of thumb. Lastly, fixed dose combinations, FDCs, like pills with 2 drugs in one.
Yeah, things like INH and rifampicin for TB. The upside is better compliance, easier to take.
But the downside?
You can't adjust the dose of each drug individually. It's inflexible.
Right. Okay, so wrapping up. ADME describes the drug's whole life cycle in the body. First-pass metabolism and those enzyme interactions are really key for dosing correctly, and TDM is vital for keeping certain tricky drugs safe and effective.
That's a good summary.
So here's something to think about. Given all these factors, absorption rates, distribution, how fast your enzymes work, kidney function, how much individual variation influences this whole ADME process, it really makes you wonder, what's the real potential for truly personalized medicine, tailoring drug therapy right down to the individual?